Thank you for the invitation to present today. My name is Christie and I'm an occupational therapist clinician researcher based in Sydney, Australia. Today I will be sharing with you a program of research from my PhD that focused on the implementation of CIMT for upper limb recovery, both in Australia and internationally. As has been discussed over the past couple of days at this symposium, you would be well aware that constraint-induced movement therapy is an intervention initially developed in the 1970s to overcome upper limb impairments after stroke. It involves constraining the stroke survivor's non-affected upper limb and completing a high-intensity, task-orientated rehabilitation program with their affected arm. CIMT is a strongly recommended intervention for people with upper limb impairment following stroke in our National Stroke Clinical Practice Guidelines here in Australia. Yet routine delivery remains rare, with a recent national audit showing that less than 12% of eligible stroke survivors in Australia received CIMT during their rehabilitation. 6 studies to date have investigated the barriers to CIMT. Across those studies, common barriers identified have included therapist-related barriers such as lack of knowledge and skills, patient-related barriers such as physical suitability for the program, and resource-related barriers such as a lack of time. However, there's been limited research to date that has reported success with tackling these barriers or that has investigated how CIMT programs have been successfully implemented into practice. My PhD program of research focused on the implementation and sustainability of CIMT programs in practice. Studies 1 and 2 investigated how CIMT is currently being delivered in practice internationally and the factors that have supported successful implementation and sustainability. In 2016, in conjunction with my PhD supervisors, Dr. Meryl Loverini and Dr. Annie McCluskey, who you would have heard from earlier, I was awarded a New South Wales Health Translation Research Grant for $330,000 for the Australian Constraint Therapy Implementation Study of the Arm, or Active Arm, as the chief investigator. Active Arm was a program of research in southwestern Sydney aiming to evaluate whether CIMT programs could be translated into practice and delivered across multiple public health services. Active Arm is comprised of 4 studies, which form studies 3 to 6 of the program of research that will be discussed today. The first study in this program of research was an online survey to investigate clinician knowledge and experiences of delivering CIMT internationally. This study has been published in the Australian Occupational Therapy Journal for those of you who are interested in gaining further information after today's presentation. This online survey sample consisted of clinicians who worked within adult neurological rehabilitation who had used CIMT in their clinical practice in the past 2 years. Clinicians were recruited to participate in the online survey via approved links with relevant professional associations for both physiotherapy and occupational therapy, neurological listservs and interest groups. Snowballing and convenient sampling were used to further diversify the sample. 169 complete responses to the survey were received. CIMT programs were most commonly delivered to people in the subacute phase 3 weeks to 3 months post-neurological event. In relation to CIMT delivery, whilst the core component of intensive graded practice was regularly included in a CIMT program, less than half of respondents reported using the core component of applying a MIT restraint, and just over a third reported using a transfer package for behaviour change. The findings from our international survey were then used to inform Study 2, an international qualitative study to further explore how CIMT was being implemented within routine clinical practice. The aim of this study was to identify and explore factors that had enabled successful implementation and sustainable delivery of CIMT programs in practice internationally. The findings from this study have been published in the Journal of Health Organisation and Management in their special issue last year on implementation science. Based on responses to the survey from Study 1, a purposive sample of participants from a variety of countries and clinical settings were then selected for recruitment to this qualitative study. Participants were required to have delivered more than 2 CIMT programs in the past 2 years and have delivered programs with fidelity to the 3 core components of CIMT based on their self-report within the survey. Participants were interviewed via video conference. Data was analysed using the Theoretical Domains Framework, a validated framework that has been used extensively to evaluate clinician behaviour change. The framework was used to identify the factors that had supported implementation and sustainable delivery of CIMT programs in practice. A number of factors were identified from this qualitative study that influenced CIMT implementation and sustainability. Whilst acquiring knowledge and skills through training supported initial uptake of CIMT, supportive social influences, including broader team support and delivery of CIMT using interdisciplinary models, as well as the environmental context, including having a supportive organisational culture and access to resources, were critical to the implementation and sustainable delivery of CIMT programs. Changes in these areas at times place the sustainability of programs in jeopardy. For example, if there was a change in organisational priorities, that may influence whether CIMT programs could be sustained. Also of note was the importance of reinforcement through seeing positive patient outcomes. Clinicians reported seeing greater outcomes than what they did when delivering other interventions, which then encouraged and motivated them to continue delivering CIMT in their practice. The findings of our survey suggest that CIMT programs are being delivered globally, but often with limited fidelity. The findings of the qualitative study highlight the importance of interdisciplinary collaboration for CIMT delivery and raise important considerations for the influence of management and broader organisational support when considering therapist behaviour change and sustainable delivery of CIMT in practice. I will now move on to discussing the Active Arm program of research, starting with Study 3, focused on designing a theoretically informed behaviour change intervention. To provide you with some further context to the Active Arm study, within my clinical role at the time of this study, I was based at Liverpool Hospital within South Western Sydney Local Health District. Stroke hospitalisations within southwestern Sydney are higher than our state average and a leading cause of long-term disability. Stroke admissions are also predicted to increase significantly in the area in the coming years with ageing and increased obesity in southwest communities. At the time of commencing Active Arm, access to CIMT in Australia was predominantly via private providers at a significant out-of-pocket cost to the individual of between $5,000 and $10,000 Australian dollars for a 2-week program. 14 of the 20 most disadvantaged suburbs in metropolitan Sydney fall within southwestern Sydney Local Health District, a community who simply couldn't afford to access CIMT privately. However, in Australia, we have an excellent universal public healthcare system. Therefore, the aim of Active Arm was to improve equity and access to CIMT within public hospitals. We all know that changes in clinical practice can be challenging. Most of our approaches to change in clinical practice are based on beliefs rather than on scientific evidence, something that has been termed the ISLAGAT principle, or it seems like a good idea at the time. This is often what occurs when we get to the end of an intensive change-based process and then realise that we haven't achieved a change in practice. And the reason being often that we haven't used behaviour change techniques or clear implementation strategies to inform practice change. Now I'm going to discuss with you the processes that we use within Active ARM, drawing on implementation science methodology and behaviour change science to inform our processes. The aim of Study 3 is to describe the development of a behaviour change intervention targeted at therapists to increase the delivery of CIMT programs by neurological rehabilitation teams in public health settings. Within Active ARM, 9 neurological rehabilitation teams containing at least 1 physiotherapist and 1 occupational therapist were recruited across 5 hospitals in southwestern Sydney Local Health District, working in inpatient, outpatient and community settings across both stroke and traumatic brain injury patient populations. Medical record audits were used at baseline to measure CIMT delivery in practice. We found that whilst around 30% of people with stroke and around 25% of people with TBI were deemed to be eligible for CIMT, less than 2% received a program. Following the collection of baseline audit data, staff focus group interviews were conducted to explore CIMT knowledge, attitudes, and organisational barriers and enablers to change, using an interview schedule informed by the theoretical domains framework. The Behaviour Change Wheel, which is a model for designing behaviour change interventions, was then used to select what behaviour change techniques and implementation strategies would be used to support therapist behaviour change. 20 key barriers and 10 key enablers were identified across 11 domains of the theoretical domains framework from the focus groups and interviews, which were perceived to influence CIMT implementation. Key barriers included lack of knowledge about who is eligible for CIMT, how to structure a program, lack of confidence, lack of resources, and decision-making processes, with therapists reporting not routinely considering CIMT in their treatment planning. Key enablers included social support with existing interdisciplinary models of upper limb management, skills with therapists reporting they felt they would be able to deliver a CIMT program after receiving some further training, and beliefs about consequences, with therapists concerned about the impact on patient outcomes and on their team's compliance with the national guidelines of currently not delivering CIMT routinely. The findings from those interviews were then used to inform the development of a CIMT implementation package to target therapist behaviour change, minimise the barriers and enhance the enablers to increase the use of CIMT in practice across southwestern Sydney. The implementation package included feedback on outcomes, which was provided to teams across the duration of the project on a quarterly basis via file audit, a 2-day training workshop to increase knowledge and skills in CIMT. A community of practice was held monthly via teleconference with local CIMT champions nominated from each team. Sites dialed in and were provided with support, coaching and positive reinforcement about CIMT delivery. And poster reminders were used as a prompt in 2 ways. The first poster targeted therapists and was placed in offices, encouraging teams to consider CIMT as an intervention in their treatment planning. The other poster targeted patients and encouraged them to ask about their suitability for CIMT and was displayed in gyms or ward areas. Finally, some drop-in face-to-face support was provided during each team's first CIMT program to assist with skill and confidence development. The next step in this process was to test the behaviour change intervention to evaluate its impact on therapist behaviour change. That then led to Study 4, a mixed methods implementation study using the RE-AIM framework. The aim of this study was to evaluate whether our purpose-designed multimodal behaviour change intervention that I've just described could change therapist behaviour and increase the number of CIMT programs offered and delivered to eligible stroke survivors and people with brain injury. This study contained multiple research questions addressing each of the key domains of the RE-AIM framework, which is often used for the evaluation of service programs in public health. However, for the purposes of today's presentation, I will focus only on the primary research question related to adoption of practice change and efficacy in relation to CIMT outcomes achieved. Two key research methods have been used to conduct this study. Firstly, 6 rounds of medical record audits and feedback, and secondly, qualitative focus group interviews. Medical record audits were used at baseline as described previously, and 3 monthly intervals for an 18-month period following delivery of the behaviour change package described in Study 3 to measure practice change. Following each CIMT workshop, each team selected a model of CIMT delivery that was suitable for their clinical context and setting, with some selecting to deliver individual programs, whilst others delivered group-based programs. Programs also varied in duration between 2 and 3 weeks, but all programs aimed to deliver a minimum of 2 hours of active upper limb practice per day of the person's CIMT program, with the MIT worn for at least 6 hours per day, in alignment with the National Stroke Guidelines. Patients who received a CIMT program at participating teams were also then invited to share their routinely collected outcome and program data to evaluate program effectiveness and program fidelity. Post-intervention interviews were completed 18 months after the completion of delivery of CIMT implementation support to explore patient recruitment methods, modifications and adaptations made to meet local needs, and any ongoing barriers and enablers affecting CIMT sustainability. This graph illustrates our primary outcome measure in relation to therapist behaviour change in the adoption of CIMT in practice. You can see from at baseline, we have almost no one receiving a CIMT program in practice. Following delivery of the behaviour change intervention and training workshops in March of 2017, you can see a significant increase in the proportion of eligible people who were both offered and then delivered a CIMT program, with delivered marked on the yellow line. Those changes continued to improve over time, and then at the final time point, 6 months after withdrawal of the implementation package, we were excited to see that the change in behaviour had been sustained, with just under 60% of eligible people being offered a CIMT program and almost half receiving a CIMT program. To provide some context, within the broader implementation science literature, a 10 to 15% change in practice is considered a positive outcome. Thus, we were very excited by our findings and that the practice change was sustained after withdrawal of implementation support. This slide highlights outcomes taken pre to post CIMT program, then 1 month following completion of CIMT. You can see across all measures, we have both clinically important and statistically significant changes in arm function and occupational performance, and these changes were sustained at the 1 month follow-up. I will now discuss our next study, which focused on the cost effectiveness of CIMT delivery in practice. The aim of this economic evaluation, which was embedded within the active arm study, was to investigate the costs and cost effectiveness of our CIMT implementation support package provided to therapists treating adults with arm impairment after stroke or traumatic brain injury, and the costs associated with CIMT program delivery. A modelled cost-effectiveness analysis from the healthcare system perspective was conducted to assess uptake of CIMT in practice and associated outcomes following delivery of the implementation package compared with standard care using decision analytic modelling. To measure effectiveness of CIMT, we used the Action Research ARM test as our primary outcome. We defined a meaningful improvement in arm function as being either achieving full marks or the minimal clinically important difference on the ARAT. Previously published data from one of the active arm sites was used for standard care estimates. Within their sample of 64 stroke survivors, approximately half were reported to achieve either the MCID or the maximum score on the ARAT between admission and discharge with standard upper limb rehabilitation. The incremental cost-effectiveness ratio was calculated by dividing the difference in costs between CIMT delivery with implementation support and standard care by the difference in upper limb outcomes or effectiveness. As you can see, the cost effectiveness of delivering CIMT with implementation support was quite high. When we conducted a series of one-way sensitivity analyses, adjusting the rate of uptake of CIMT and scale-up of CIMT implementation had limited effect on changing the incremental cost effectiveness ratio. However, when we removed the costs associated with therapist time to deliver a program and instead considered it being delivered within usual care rather than as additional time, this resulted in a large improvement in cost effectiveness with an ISA of $1,505. That's equivalent to just over $1,000 US for both individual and group-based CIMT programs. We then conducted a scenario-based analysis where we combined multiple factors. In this best case scenario, we presumed that 80% of eligible people received CIMT, 67% of those who completed CIMT achieved a minimal clinically important difference or full marks on the ARAT based on patient outcome data from our study, and that only the additional costs of the implementation package were paid for by the health service, with staff time reallocated from existing resources. This brought the ISA to just $245 per person, gaining meaningful improvement in their arm function. The final study I'm going to discuss today focuses on the experiences of people who participated in a CIMT program. In this final study, we sought to investigate the experiences of people who received a CIMT program. Within the existing published literature, therapists frequently report patient-related barriers to the delivery of CIMT. They report issues with patient motivation and patients' ability to tolerate the intensity of CIMT as key barriers, yet there's been limited exploration of experiences of the CIMT participant. We therefore sought to explore this and to investigate the barriers and enablers to participation using the capability, opportunity, motivation, behaviour model. We interviewed 45 CIMT participants 1 month after completing their CIMT program. We used an inductive approach to thematic analysis with 3 interview transcripts coded collaboratively to develop an initial coding framework, then 17 subsequent interviews double coded independently. Results were compared and discussed to clarify the coding framework, and 1 researcher then coded all remaining interviews. The codes were then mapped to the capability, opportunities, motivation, behaviour model of behaviour change as a framework for understanding behaviour and the motivators and barriers to participation and adherence to a CIMT program. Key enablers to participating in a CIMT program were being provided with education about the program, including expectations of both the stroke survivor and their family member, social support from staff, other stroke survivors in group-based programs, family, and allied health students. The structured nature of the program was found to be useful, and many people who completed the program as inpatients reported that it was a great way to fill the time, which I think is particularly interesting as we have a number of observational studies that now demonstrate to us that people spend a lot of time inactive and alone during inpatient rehabilitation. So that for those who are suitable for CIMT, this could be a great way to provide them with an evidence-based intervention that also addresses that gap. Barriers to the program included mental and physical fatigue, and finding the exercises could be boring and repetitive at times. In terms of perceived benefits and outcomes of the program, the majority of participants stated they would recommend CIMT to others, as CIMT had improved their arm function. They perceived they had achieved faster improvements by completing CIMT, and CIMT had provided them with tools to continue to practice independently. Other benefits seen from the program were overcoming learned non-use, increased functional independence, including some participants reporting they felt that this had contributed to them being able to return to living at home. Whilst a smaller number of participants reported seeing minimal improvement in their arm function after their program, others reported improvements in strength, movement, and in one case, a reduction in pain. Participants also reported that CIMT had helped to support them to return to valued roles and activities, including returning to work roles and valued hobbies such as fishing and playing the piano, as outlined in the quote there on your screen. In summarising this program of research, we designed and delivered a theoretically informed behaviour change intervention and were able to address an important evidence practice gap and improve CIMT delivery in practice. With financial investment to support initial implementation and ongoing training and support, CIMT results in important improvements in arm function for patients. CIMT, provided in our best case scenario as part of our economic analysis, represents good value for money and can be considered cost effective, although this is difficult to definitively say without a clearly established threshold. Alternative models of CIMT delivery may help to support cost effectiveness. Additionally, we identified that support is required to assist stroke survivors and people with brain injury in decision-making in relation to accessing evidence-based interventions. Ongoing support is also required for the implementation of complex interventions like CIMT. Education alone is unlikely to change practice, and sustainability is critical. So access to booster training sessions and ongoing support, such as was demonstrated through our community of practice, as well as organisational and leadership support, are critical requirements to help support the sustainability of CIMT programs in practice. Support is also needed for patients and their caregivers, and this is particularly important in the first few days of their program. In terms of future research directions, whilst we achieved good outcomes within the Active Arm project, you will have noted that we found that even when therapists are skilled and motivated to provide CIMT, almost half of eligible stroke survivors declined to participate, and the reasons that they declined remains unknown. To date, there's been limited research exploring the acceptability of CIMT from a stroke survivor's perspective. It's well established that when patient preferences for treatment are taken into account, uptake and adherence improves, leading to better health outcomes and improved cost effectiveness. Designing CIMT programs that align with patient preferences is likely to improve both patient uptake and the cost effectiveness of upper limb rehabilitation post-stroke. We plan to conduct a discrete choice experiment in 2022 to identify patient preferences in relation to CIMT delivery. Finally, in terms of future directions, As a consequence of the COVID-19 pandemic in 2020, in collaboration with colleagues Jessame Boydell from the United Kingdom, Annie Ma from the United Kingdom, and Anna Kilkenny from New Zealand, we developed a suite of resources to help support the delivery of CIMT via telehealth. These resources are freely available at the website that's shown on your screen. In 2022, with the support of a St Vincent's Clinic Foundation multidisciplinary grant and an Australian Stroke Foundation Early Career Researcher grant, we will be conducting a pilot implementation efficacy trial to evaluate the delivery of CIMT via telehealth across 3 public health outpatient clinical settings in Sydney, Australia. In addition, my colleagues in Chile will look to replicate this study to see if they also achieve similar outcomes. In closing, I would just like to thank the organisers for the opportunity to present to you today and to acknowledge the amazing Active Arm team, including my PhD supervisors, Dr. Meryl Loverini, Dr. Annie McCluskey, and Dr. Alison Pearce, and research officers Reem Rendell and Nicola Fern, as well as the OT and Physio departments of Southwestern Sydney LHD who participated in this study, and my colleagues in the TIDE group, Jessame Boydell, Annie Ma, and Anna Kilkenny, who co-designed the TeleCIMT website. Thank you.